Hello everyone. Today I will be discussing a case study regarding the use of scleral lenses in a patient with advanced keratoconus. So this presentation will be having 4 different parts. We will begin with a brief case summary, followed by how we went ahead with fitting scleral lenses in this patient. Finally, the outcome and the learning points which we can take home from this presentation. So the story begins with a 25-year-old female who came to us in a lot of distress. She presented with complaints of pain, watering, and sudden whitening of the right eye for the past 2 weeks. Her past history was significant for poor vision in both eyes since adolescence. So this lady had never really seen the world properly. She had frequent changes in spectacle power, and in spite of numerous glasses, her vision never really improved. So when she noticed pain, watering, and sudden whitening of the right eye, she was understandably quite alarmed. On examination, this is what the right eye looked like. My immediate impression was that this is a patient of acute eye drops, and we treated her conservatively with topical medications and responded well. Since I am suspecting acute eye drops, it's only natural that I have to examine the other eye. Now, the other eye was a frank case of advanced keratoconus. As can be seen here, these are photos taken by me of this patient. You can see the pronounced cone in the left eye from a side profile. And when we did the slit lamp examination, you can notice that there are multiple vote striae in the visual axis, which can be shown by the arrow here. Her visual acuity was counting fingers 2 meters in the left eye, and it was unfortunately not improving on retraction. Her corneas were very thin, hence ruling out the possibility of doing collagen cross-linking in this patient. We went ahead and performed a corneal topography for this patient, and as you can see here that this is a sea of red, just signifying how advanced the keratoconus is. She had a Kmax of 72.89 diopters, which makes you understand the magnitude of the problem she was facing. So now we had to plan regarding the management for this patient. For the acute corneal eye drops in the right eye, we needed to plan an optical keratoplasty. For the advanced keratoconus in the left eye, we needed to plan for scleral lenses because collagen cross-linking was out of the picture here. So we could not perform the optical keratoplasty in the right eye straight away because we needed the acute eye drops to settle down first. While we waited for the eye drops to settle down, the patient was still visually impaired because of her poor vision in the left eye. Keeping this in mind, we made the decision to go ahead with fitting scleral lenses in the left eye first. So this will give a quick and effective solution to her immediate visual needs. She will start seeing well in the left eye, and subsequently we will go ahead and perform the keratoplasty in the right eye. With this in mind, before I go ahead to the fitting of the patient, I just like to speak a few words about what a scleral lens is. So scleral lenses are a special type of contact lenses which are a boon for patients with irregular cornea like this lady. What it does is it forms a reservoir between the back of the lens and the front of the cornea, which is filled with liquid. So this eliminates the irregular astigmatism component for the patient and greatly enhances the visual quality, as you will see in this case. This is what a scleral lens looks like. So the green thing is a plunger which is holding the lens in place. It is a hard lens. So this particular lens is made up of a material known as Boston XO2. So they have excellent oxygen permeability nowadays, and it is shaped like a bowl where you fill the fluid. So these were the parameters which we used while going ahead with the Scleral Lens trial. I intentionally chose a base curve of 7.1 millimeters so as to accommodate the steeper cone. The fit was evaluated at 20 minutes, 1 hour and 3 hours. The final over refraction was minus 0.75 diopter sphere with the vision improving to 6 parts. Needless to say, this was an excellent result for us. So this was the final set of parameters when I placed my audit. The patient came in for dispensing, and this is what the lens looked like on the eye. So these are taken with my slit lamp. So I would just like to point out the edge of the scleral lens here. As you can see, this is the edge of the scleral lens. Take a close look at the blood vessels here. The blood vessels look normal. If this area appears white or you notice blanching of the limbal blood vessels, then the lens is too tight. You need to adjust the parameters accordingly. Since the vessels are seen normally here, it is suggested that the fitting is good. Other than the vessels, you need to check for the vault. So this is what a vault looks like. So this is again taken on my slit lamp, and I'm moving from nasal to temporal. You can see the green colored fluid between the cornea and the lens pack surface. So that is what is known as a vault. Good vault should at least be 250 microns, if not more. I deliberately chose a higher vault for this patient in view of the advanced keratoconus and the possibility of progression in the future. This is what the lens looked like on the eye. She had an excellent visual acuity of 6 parts with scleral lenses. The vault was adequate. There was good tear film exchange. There was no blanching of vessels, and the patient, most importantly, was comfortable. Needless to say, she was extremely happy with the outcome in this eye. And we are planning to perform a right eye optical keratoplasty pretty soon for the eye drops. So when you are dealing with advanced keratoconus and you're planning scleral lenses, go for steeper base curves. Otherwise, you will not get a good vault. A good vault is a must for any scleral lens. If the vault is shallow or there is a corneal touch, it's not a good thing. Similarly, if the vault is too high, that's not good either. And most importantly, spend a lot of chair time with the patient before dispensing the lenses. Chair time before dispensing saves you a lot of chair time after dispensing. Make the patient practice inserting and removing the lenses in front of you. Teach her how to take care of the lenses. There are a lot of resources on YouTube, but when you sit down and explain it to the patient, it will always have a much greater impact. To sum up, scleral lenses are safe, effective, and can produce a miraculous improvement in vision for these patients. This is where I work, and thank you so much for your time. These are my contact details. Please feel free to get in touch for any queries. Thank you.